Hello, and welcome to Oral Pharmacology, Chapter 2, Fundamentals of Drug Action. The goal of this chapter is to provide an understanding of the basic principles of what the body does to drugs and the action of drugs on the body. After reading this chapter, you should be able to compare the differences between pharmacodynamics and pharmacokinetics, describe the common routes of drug administrations, describe the mechanism of drug absorption through the various membranes in the body, describe absorption through the different routes of a drug administration, describe the drug receptor interaction, distinguish between a loading dose and a maintenance dose, describe the various factors involved in the biological variations of drug dosing, and list and discuss different types of drug effects. Key terms of this chapter are drug administration, pharmacokinetics, remember what the definition of that is, drug clearance, drug doses, pharmacodynamics, remember that definition, drug receptors, drug effects, adverse drug events, and adverse drug reactions. Let's talk about the drug administration. Remember that a drug enters the bloodstream by absorption, according to where it is administered. Once again, remember a drug enters the bloodstream by absorption, according to where it is administered. The route of its administration influences the degree and rate that the drug is absorbed. There are three basic routes of drug administration. One is the enteral administration. The second one is parenteral administration. And the third is topical administration. The enteral route of administration involves the drug being absorbed from the GI tract, and this includes orally by mouth, the Latin term being PO. It can be administered sublingually, which is under the tongue. It can be administered buccally, which is between the cheek and the tongue. And it can be administered rectally, which is through the rectum, or PR. The oral enteral administration is the most common. It's the most acceptable and convenient route for patients when prescribed, often written as PO in your prescription, which refers to taking the medication by mouth. There's also sublingual and buccal enteral routes of administration. And these drugs are taken under the tongue or between the cheek and the tongue and are absorbed directly through the oral mucosa. The rectal enteral administration is a common route for infants, children, or older adults. The drug is in the suppository form when it's too irritating to the stomach to take by mouth. If the patient is vomiting, for example, or if he's nauseated, he can't swallow a pill or for a local effect. And these are examples of these types of enteral administrations would be for lesions of the rectum or colitis. Let's talk about the parenteral route of administration. This delivers the drugs via a needle into the skin layers at different angles. One of the angles is IV, which stands for intravenous. It's injected directly into the bloodstream through a vein. This is the most common route used for emergency situations when it's critical to get the drug into the bloodstream as soon as possible. Examples are these are fluids or any type of antibiotics. Once again, IV, it's injected the drug directly into the bloodstream through a vein, and this is the most common route used for emergency situations when it's critical to get the drug into the bloodstream as soon as possible. IM, or intramuscular administration, is administered into the layers of skeletal muscle beneath the skin. Absorption is rapid and uniform due to the large amount of blood vessels. An example of this would be the hepatitis B vaccination. The subcutaneous or SC injection. This is injected into the connective tissue under the skin. This is how we administer dental anesthetics as well as insulin. The intradural administration is injected directly into the dermis layer of the skin below the epidermis and is used for testings. Examples of these are any type of allergens or TB tests. An intrathecal, and these types of administration is delivered into the spinal fluid, the spinal anesthesia. An example of this is when you're delivering. This is epidural, is a common administration of a drug. This is a less common parental route. And table 2.1 in your book, it's a great diagrammatic picture of how these different drugs are administered. As you can see, the intramuscular is perpendicular to the epidermis. The subcutaneous injection is 45-degree angle to the epidermis. The intravenous or IV injection is at about a 25-degree angle to the epidermis. And the intradermal is into the top layer of the epidermis, usually a 10 to 15 degree inclination. So remember the intramuscular and the angles that each one of these types of administrations are administered: subcutaneous, intravenous, and intradermal. Another route of administration is the topical administration. And this is the application of the drug directly to the surface of the body where the action is desired. An example, it can be placed sublingually, which is applied topically into the gingival crevice. Examples of these are Oraquix, and periotips that you will soon be introduced to if you haven't already. Inhalation is a topical administration, where the drugs are inhaled through the mouth or nose. And examples of these are nitrous oxide, asthmatic type of inhalers, and general anesthesia. Another example for topical administration would be an ophthalmic, where it's administered to treat local conditions of the eye. And these can be administered through drops due to dryness or to dilate the pupil during eye examinations to detect glaucoma. Another topical administration example would be otic, where the drug or drops are, in the form of drops, are administered directly into the ear. Or transnasal, we have nasal sprays for both local and systemic effects, and these are provided as nasal sprays or drops. And transdermal, where you have the application of the medicated adhesive patch to the skin, delivering time-release doses of meds through the skin to the blood. An example of this would be a nicotine patch. And as you can see in the first column, it names the different route of administrations. The second column is the advantages and disadvantages, and the third column gives you examples. So just remember, the transdermal is a dosing over an extended period of time and low doses of the drugs. And it cannot be given in large volumes of drugs, and it's not a very rapid response. Subgingival is localized effect to oral mucous membranes, gingival crevice, and skin, and it's only used to treat localized subgingival areas. The epicutaneous types of administrations are localized effect on the skin and only treats local areas. And inhalation, where there's a rapid drug response, a local effect to the lungs, and generalized effect with general anesthetics. And you cannot give these in large volumes of the drug. Pharmacokinetics. And what is this? It's the amount of drug in the body at any given time, and it's determined by 4 processes. Remember ADME? And you remember what that stands for? It describes what happens with the drug once it enters the body, and how a drug is absorbed, where it goes, and how the body gets rid of it. And what does ADME stand for? Absorption, distribution, metabolism or excretion, and elimination or exit. ADME. That's the definition of pharmacokinetics. How a drug is absorbed by the body, how it's distributed through the body, how it's broken down or metabolized in the body, and how it's eliminated by the body. Now, the ultimate goal of pharmacokinetics is to have the drug reach the site of action in adequate concentrations to produce a pharmacological effect prior to being eliminated. Figure 2.2 in your book shows the scheme showing the concentration of absorption, distribution, metabolism, elimination, and drug-drug receptor binding of the drugs. As you can see, the drug is given. It is then liberated in the area where it is administered. Pharmacokinetics takes over of the particular drug. It's absorbed, distributed, metabolized, eliminated. And then the pharmacodynamic occurs at the receptor binding site, where it causes a pharmaceutical effect, both therapeutic and adverse. And this is a two-compartment model of pharmacokinetics. This is just a diagrammatic showing of the blood and the plasma, how it is eliminated. Some of it's eliminated, being unbound. Once it's bound, it can go through the distribution stage, reach the tissues, and either be bound or unbound in the tissue form itself. In an unbound stage, it can either be eliminated, further broken down into metabolism by metabolizing and then eliminated through the body. Let's talk about absorption. How does a drug get into the blood? A drug must be in solution to be absorbed and distributed in the body. Drug passes through the GI tract, where most absorption occurs in the blood, into the blood, and the duodenum or duodenum or small intestines. Remember, a drug passes through the GI tract where most absorption occurs into the blood, through the duodenum or small intestine. Before a drug is absorbed into the blood, it must move across many cell membranes to get to the target organ to exert their action. Before a drug is absorbed into the blood, it must move across many cell membranes to get to the target organ to exert their action. Generally, a drug will be better absorbed in the small intestine than in the stomach, because the small intestine has a larger surface area. Remember that. Generally, a drug will be better absorbed in the small intestine than in the stomach, because the small intestine has a larger surface area, more blood vessels. The movement of drugs. Cell membranes, tissue barriers are composed of two layers of lipid. A biphospholipid layer with highly polar, which means water-soluble heads of the molecules oriented outwards, and nonpolar, which are fat-soluble chains of fatty acids inside the membrane. Remember this slide. Cell membrane tissue barriers are composed of two layers of lipids, biphospholipid layers with highly polar, water-soluble heads of the molecules oriented outwards, and nonpolar fat-soluble chains of fatty acids inside the membrane. They're embedded in the membranes are proteins with small water holes, channels, or pores throughout. So they're difficult to visualize. So let's go on to the next slide to give you a better understanding. Figure 2.3 is a diagram of a cell membrane. As mentioned, the cell membrane is a double layer of phospholipid molecules with highly polar heads oriented outward. Highly polar heads, water soluble, and nonpolar chains of fatty acid inside the membrane, Embedded in the membrane are proteins that included ion channels for transport of water-soluble drugs. Polar heads on the outside, as you can see, the bottom of the page there, it's a single layer, water-soluble. Lipid layer, fat-soluble, inside, below the water-soluble. And you have proteins as well as water pores within the membrane itself, little channels where drugs can enter. Remember this diagram. Let's talk about the movement of drugs. Optimally, a drug should have both lipid and water solubility. Water solubility to go through fluids to get into the cell, and lipid solubility to get through the cell membranes completely. Remember, lipid solubility is one of the most important determinants of the pharmacokinetic characteristics of the drug. In other words, the more lipid soluble a drug is, the better and faster chance that it can reach its receptor site. Pharmacokinetics. The drug must go through many cell membranes before it reaches the general circulation to be distributed to the site of action. There's a biphospholipid layer, a lipophilic or lipid-soluble layer, a hydrophilic or water-soluble layer, and optimally a drug should have both lipid and water solubility. Water solubility to go through fluids to get to the cell, and lipid solubility to get through the cell membrane itself. Once again, lipid solubility is one of the most important determinants of the pharmacokinetic characteristic of a drug. There are different types of cell membranes in the body. Oral drugs pass down the esophagus into the GI tract, the small intestine, where it must cross the GI mucosa, which is a single cell layer epithelium, into the blood and distributed to its sites. This is referred to as the intestinal mucosa blood barrier. Intestinal mucosa blood barrier. Oral drug passes down the esophagus into the GI tract, small intestine, where it must cross the GI mucosa, which is a single layer of cells, into the blood and distributed to its site. The oral mucosa is a blood barrier. Most drugs go through the epithelium of the oral mucosa before entering the blood and being distributed to the site of action. Oral mucosa blood barriers go through the epithelium of the oral mucosa before entering the blood and being distributed to the site of action. Once a drug enters the blood, it is transported to the various parts of the body where it will exert its effects going through another barrier, the membrane between the blood and the tissue, which is called the blood-tissue barrier. The placental barrier, it filters out some substances that can harm the fetus, but allows other substances like alcohol to cross. That's why it's important if you're pregnant to refrain from heavy alcohol use, because it passes the placental barrier. The blood-brain barrier allows lipid-soluble drugs, such as general anesthetics, to go through the cell membrane, and where water-soluble drugs cannot enter the brain. Only lipid-soluble drugs can. Figure 2.4 shows the absorption of a drug through cells into the bloodstream. The drug has to go through many tissue blood barriers to get to the final site of action. The tissue blood and blood tissue barriers are, after swallowing a drug, it goes to the GI tract, which is a small intestine, gets into the blood, then from the blood through the blood tissue barrier, goes to the site of action, either to an organ or tissue. And you can see it's a drug and a carrier. Substances move through cell membranes by passive diffusion. Most drugs absorb this way across their cell barriers. The rate of absorption increases as long as the concentration outside the blood, the cell, is greater than the concentration inside the cell, GI fluids. So remember that the rate of absorption increases as long as the concentration outside the cell of the drug is greater than the concentration inside the cell. No energy is used by this particular cell to get substances through the cell membrane. A facilitated diffusion occurs when a carrier, such as a protein, is necessary to get a drug that is too large or too polar to diffuse across the lipid membrane. No energy is used by this cell. This is facilitated diffusion. Active transport. This involves the use of some type of carrier protein to move the drug against the concentration gradient with some type of expenditure of energy. Pinocytosis involves the engulfment of fluids or particles by a cell with the expenditure of energy. Forms a vesicle that will detach and move to the interior of the cell. And once again, this involves energy expenditure. So the active transport and the pinocytosis both have expenditure of energy. How does it have the effect of the pH on absorption? Most drugs are either weak acids or bases. Look at table 2.2. And are present in solutions as both ionized and non-ionized forms. Remember that the non-ionized form is usually lipid soluble and readily crosses cell membranes. So always put together those two words, non-ionized, lipid soluble. And these types of drugs readily cross cell membranes if they're non-ionized and lipid soluble. How much of the drug changes to the ionized form will depend on the pKa of the drug and the pH of the solution. What is pKa? pH, it is the pH that produces 50% ionized and 50% non-ionized molecule. Half and half ionized, half non-ionized. That is what the pKa of a drug is. It's the pA that produces 50% ionized, 50% non-ionized. Remember, ionized is a water-soluble charged ion. Non-ionized is uncharged, lipid-soluble, non-polar. Generally, the pKa of weak acids is between 3 and 5, and weak bases is between 8 and 10. pKa of weak acids 3 to 5, pKa of weak bases 8 to 10. Table 2.2 are examples of weak acids and weak bases. Weak acids: aspirin, penicillin V, phenytoin, tetracycline. 3 to 5. Weak bases: caffeine, codeine, erythromycin, pilocarpine, which is used in the treatment of dry mouth, local anesthetics, and diazepam. Eight to 10. The pH refers to the concentration of hydrogen ions. pH refers to the concentration of hydrogen ions. Ionized are charged forms of a drug, and they have low lipid solubility and cannot easily cross the lipid membrane. The degree or amount of absorption from the gut into the bloodstream is dependent upon the lipid or fat solubility of the drug. Only non-ionized, uncharged, lipid-soluble drugs will be absorbed across cell membranes of tissues. Remember that the cell membrane is composed of biphospholipid layers. The degree or amount of absorption from the gut into the bloodstream is dependent upon lipid or fat solubility of the drug. Only non-ionized, uncharged lipid-soluble drugs will be absorbed across the cell membranes of the tissue. Remember that the cell membrane is composed of a biphospholipid layer. Very important. Drugs that are weak acid, for example, aspirin, have a pKa 4.4, penicillin 2.5 will be mostly non-ionized at the acidic pH of the stomach, pH of 2, allowing them to be readily absorbed. Remember, weak acids 3 to 5. In theory, weak acids are more readily absorbed from the stomach than weak bases. Figure 2.5 shows the effect of pH on drug absorption. In A, you have a weak acid such as aspirin in a non-ionized form in an acidic environment, and it absorbs very quickly. However, in a basic environment, aspirin is mostly in an ionized form, and its absorption is prevented. Movement of a drug through the body, which is pharmacokinetics, is absorbed, distributed, metabolized, and then excreted in the body. And here is an example of the pathway that drugs take. Now they're pharmacokinetically broken into the different forms. Absorption. On the other hand, drugs that are weak bases, such as erythromycin, codeine, and morphine, will be more non-ionized at the pH of the basic small intestines, 6 to 7, and ionized in the stomach, which has a pH of 2. So the non-ionized portion of the drug shows greater lipid solubility and therefore greater absorption in the small intestine. Regardless of the pH and ionization, most drug absorption, even of weak acid, occurs in the small intestines, which has the greatest surface area. Remember, regardless of the pH and ionization, most drug absorption, even of weak acids, occurs in the small intestine, which has the greatest surface area. Local anesthetics are weak bases. Lidocaine, for HCl, for example, is a type of anesthetic that you will be injecting. All anesthetics, remember, are acidic prior to being injected. Local anesthetics are weak bases. All anesthetics are acidic prior to injection. Local anesthetics are weak bases. After the injection, the solution quickly takes on the pH of the surrounding tissues. The surrounding tissue can either be charged or uncharged. The pH of the surrounding environment determines whether the anesthetic will be charged or uncharged. For example, when you have an infection, that particular area is very acidic. It's charged. And if you inject an anesthetic, it reduces the effects of the anesthetic. So if you have an infection there, the local anesthetic that you're going to be using is less effective. If you have a neutral or uncharged lipid-soluble type of situation, the anesthetic is easily crossed through the membrane and therefore gives you fast, profound anesthetic. So remember, in an acidic environment, the effects of the anesthetic is reduced. Since local anesthetics are weak bases, the closer the pH of the local anesthetic is to the local tissue, which remember, the pH of local tissue is 7.4. That's important to remember. The more non-ionized the drug is, the faster it will be absorbed with a quicker onset of action. The closer the pKa of local anesthetic is to this local tissue pH, which is 7.4, the more non-ionized the drug is and the faster it will be absorbed with a quicker onset of action. Okay? If you use an anesthetic that has a pH close to 7.4, it's going to move rather quickly and be more effective. Lidocaine with a pKa of 7.9 has a faster onset of action than bupivacaine, which has a pKa of 8.1. It's further away, it's greater than the local tissue pH of 7.4. Therefore, the onset of action is less, and it will not be as effective. If the local tissue pH is more alkaline and closer to the pKa value of the drug, the onset of action is also faster. And remember, in the presence of inflammation, like an infection, the local tissue environment becomes very acidic. Thus, there is less local anesthetic in the basic form and the non-ionized form than it is required to cross the nerve cell membrane. What factors affect absorption? Your blood flow. Increase blood flow to the organ, you increase the absorption of that particular drug or anesthetic. Nitroglycerin is an example. It's administered under the tongue and it's very quickly absorbed. Other factors are large surface area, such as the small intestines. The greater the surface area, the greater increase the rate of absorption and effectiveness. The salt form of a drug. If you increase the salt form of a particular drug, you're going to increase the solubility of it. So let's talk about the enteral absorption. And these are basically, remember, oral administered drugs, enteral form of administration drugs. These drugs are taken orally, they're absorbed from the gut through the GI tract into the blood. On the bloodstream, the drug goes into the liver, to the hepatic portal vein, where it is partially or totally metabolized. And when it goes from the bloodstream directly to the liver hepatic portal vein, this is called the first pass effect and is a major disadvantage to the oral route. The absorption may be very slow through this route. The sublingual route bypasses the liver. And figure 2.6 shows you diagrammatically the first pass route of a drug that's being absorbed orally. If the drug is partially metabolized, it goes back into the general circulation and is then distributed to the target organ. Once again, this shows the movement of a drug through the body. Pharmacokinetics, the way it's absorbed, distributed, metabolized, and excreted. Parenterally administered drugs bypass the liver. The first pass effect. IV drugs are injected directly into the bloodstream. So remember, parentally administered drugs bypass the liver, which is the first pass effect. It bypasses that. And the IV drugs are injected directly into the bloodstream. On table 2.3 in your book shows a summary of the drug action and common routes of administration. Shows the tablets or capsules taken by mouth with a glass of water. The tablet goes down the esophagus. The drug goes into the stomach, where a tablet is broken up. Capsule form opens up, and the active ingredients in the drug are dissolved. The drug goes into the small intestines, where most of the drugs are absorbed. The drug must cross the intestinal mucosal blood barrier first. The lipid-soluble drugs, remember, are absorbed more easily because the intestinal barrier is a lipid membrane. After absorption from the small intestine, the drug goes through the portal vein into the liver. As drugs go through the liver on its way to the blood, some will be metabolized extensively and inactivated before becoming available to the body, which is the first pass metabolism in the liver. From the liver, the transformed drug goes to capillary blood vessel barriers through the superior vena cava into the bloodstream for distribution into the body. After the drug exerts its pharmacological action, it will either be eliminated unchanged if it's in the hydrophilic drug, or metabolized in the liver by liver enzymes to a water-soluble form that will be readily eliminated by the body, which is excreted through the kidneys and the urine. Some drugs, which are examples of these, are large polar drugs, estrogen, rifampicin, digitoxin, phenytoin. They undergo enterohepatic recirculation, where they are excreted from the liver into the bile, then they're reabsorbed from the intestine, returned to the liver, and eliminated in the bile. Drugs that are sufficiently lipid-soluble are more readily absorbed and distributed orally. However, lipid-soluble drugs must first be converted to the liver into water-soluble metabolites that can be excreted by the kidneys. Table 2.3 shows a summary of the different drug actions for common routes of administration. IV, the drug is injected directly in the blood and is rapidly distributed to the tissue. In the blood, some drugs are extensively protein-bound. The first pass metabolism is eliminated, therefore, there are no barriers to absorption. 100% of these drugs are bioavailable. After distribution, the drug is excreted in the urine by glomerular filtration. Enterohepatic circulation, metabolized by the liver, and it can also be eliminated in the bile. Let's talk about the topical drug routes. These drugs are placed on the mucous membranes. The dental topical anesthetics, for example, benzocaine and lidocaine. They're absorbed through the oral epithelium, and these drugs placed into the squinchal crevice. Examples of these will be periotrip, Arestin, Orchic, and they're absorbed through the sulcular epithelium. Once a drug is absorbed from the GI tract into the bloodstream, it's distributed or transferred throughout the body fluids to tissues and organs. Distribution may be restricted to the extracellular space, the plasma volume plus interstitial space, or it may also go into the intracellular space, which is within the cell. So the distribution can be restricted to either being outside of the cell space or within the cell itself. What's the volume of distribution of a drug? Well, this describes how widely a drug will be distributed. Some drugs stay in the blood. Some drugs go from the blood to the extracellular fluid and won't go any further. Some drugs will go into the cell intracellular. The low plasma volume drugs means that the drug's distribution is restricted to a particular compartment. For example, the extracellular fluid or plasma. The high plasma volume indicates that the drug is concentrated intracellularly with low concentrations in the plasma. A loss of drug concentration may occur during this distribution phase due to many factors. Many drugs are bound to plasma proteins, which are proteins found in the plasma. Drugs that are plasma protein bound are in an inactive state. Remember, only the free drug, not the plasma protein bound, is active. Drug displacement, once the drug competes with another drug for binding sites, then another drug is displaced. So once a drug attaches to a receptor site, another drug cannot bind to that particular site, and that's called drug displacement. A loss of drug concentration may occur during the distribution phase due to many factors. Absorption across various lipid membranes and into the body fat can be eliminated from the body in the free form or as a metabolite after going through the liver. And blood flow. The greater the blood flow to an organ, the greater the rate of distribution of the drug throughout the body. Protein-bound drugs. While in the bloodstream, drugs have the opportunity to either exist in free form, which means they're not bound, or be reversibly bound to many proteins, primarily albumin, which is referred to as plasma protein binding. Remember, while in the bloodstream, drugs have the opportunity to exist in the free form, not bound, or be reversibly bound to many proteins, primarily albumin, which is referred to as plasma protein binding with albumin. The extent of the affinity of a drug for protein binding sites ranges from 10 to 99%. The highly protein-bound drugs such as warfarin and aspirin have a low volume of distribution. Drugs that are protein-bound are in an inactive state. Only the free drug is active. The two drugs that bind to the same site on the protein compete for the binding if they are present in the plasma simultaneously. Once the drug will displace the other drug from the site, elevating the free concentration of the displaced drug, which can result in toxic level of the drugs. In Figure 2.8 shows plasma protein binding and drug availability. In A, the drug exists in a free state or bound to plasma protein. B, the drug protein complexes are too large to cross the membrane. Therefore, they're not very available. They're not very effective. They can't cross through the membrane. Distribution, competitive displacement of drugs from protein binding sites, which is two drugs bind to the same site on a protein. They're limiting the binding sites. One drug can displace the other drug. They're short-lived because the increased free drug concentration will accelerate the drug metabolism and excretion. After a drug is distributed to a tissue or organ and exerts its pharmacological action, it must be eliminated from the body. Elimination is the disappearance of the active drug from the bloodstream or body. Excretion is elimination through the kidney and out of the body in the urine. Drugs are eliminated either as the original parent compound or as a drug metabolite. The resultant drug compound after metabolism or biotransformation from the body through many different routes, including the kidney, the most common route, bile, feces, skin, sweat, saliva, or lungs. So drugs are eliminated either as an original compound or as a metabolite, broken down through different routes: kidney, bile, feces, skin, sweat, saliva, or lungs. Generally, polar drugs that are not metabolized are excreted unchanged in the urine. There are two major routes of elimination. Excretion. The most common route for drug excretion is through the kidneys and out of the body in the urine. Water-soluble, hydrophilic drugs are easily excreted to the kidneys. It's more liquid. Insulin is an example of a hydrophilic drug. And drugs can be eliminated through biotransformation. To be readily eliminated from the body, a drug must be in a water-soluble polar form. Thus, many drugs must be changed or biotransformed before it's eliminated, and the liver is the primary site of drug biotransformation. Remember, the liver is the primary site of drug biotransformation. Why does a drug have to be biotransformed? It has to be biotransformed in order for it to be eliminated. For example, lipophilic or lipid-soluble drugs need to be biotransformed or altered in the liver to be more hydrophilic, water-soluble, that could then be more easily eliminated from the body. Lipophilic or lipid drugs need to be biotransformed or altered in the liver before being eliminated. A lipid-soluble drug must become less lipophilic and more water-soluble so that it is more easily eliminated by the kidneys. Remember, after the drug is biotransformed, it is referred to as a metabolite. Oral drugs that are inactive and become active only after metabolism in the liver. Examples of these are levodopa, which is used for Parkinson's disease. That needs to be metabolized to dopamine in the liver in order for it to be active. Lotensin, which is an antihypertensive drug. Losartan, which is a heart medication. Some drugs are not metabolized in the liver and continue to be eliminated from the body as unchanged. Lithium is an example of this, and it's used for bipolar or manic depressive disorder. You have different types of phases of metabolism. Phase 1, it involves enzymes in the biotransformation of drugs. In phase 2, the drug or metabolite from phase 1 is conjugated or linked with highly water-soluble compounds such as glucuronic acid to make it more water-soluble so that it can be easily excreted through the urine. It's kind of a blurry slide of the table 2.4, which shows the metabolism of drugs, features of phase 1 and 2. Phase 1 carried out in the liver. Phase 2 conjugated with highly water-soluble. Enzymes found in the liver, cytochrome P450. It's responsible for drug biotransformation or breakdown of drugs. There are a large family of cytochrome P450 enzymes. Just remember that this is enzymes that are found in the liver, and they are responsible for the drug transformation or the breakdown of drugs. Cytochrome for P450. Substrate, the drug being metabolized. Some drugs are inducers of the P450 enzymes, meaning they stimulate the action of certain enzymes to break down certain drugs, which decreases the drug's blood levels and makes it less active. It's broken down more quickly. Some drugs are inhibitor of the P450 enzymes, and they inhibit the breakdown of certain drugs, which increases their blood levels and may cause toxicity. The result, if the two drugs are taken together, they will inhibit the metabolism, resulting in eliminated plasma levels. The management is simply don't take two drugs together. Space them apart. Example is the fluconazole, which will inhibit the metabolism of clarithromycin, resulting in elevated levels of clarithromycin plasma levels. Don't take two drugs together, space them apart. Kidney excretion. Plasma containing the drug and other substances is forced through capillary blood vessels and into the glomerular capsule. Large molecules in the plasma, such as proteins and cells, are filtered out and they remain in the blood. The resultant fluid that enters the capsule is called glomerular filtrate. Substances not removed by filtration because they're too large, or some weak acid and bases, are eliminated by active, requiring injury tubular secretion into the urine. Beside active secretion, selective passive reabsorption of substances useful to the body, water, glucose, salt, back into the blood takes place in the tubules. Lipophilic or lipid-soluble drugs will be actively reabsorbed passively from the tubule back into the blood because they need to be metabolized into metabolites before they are excreted. Some drugs are excreted in the bile by a process called biliary excretion. Enterohepatic recirculation. These are the recycling of drugs and other substances by the circulation of bile through the intestine and liver. Enterohepatic. And figure 2.9 just as an illustration of the enterohepatic recirculation. Certain drugs are secreted into the bile and eventually are eliminated in the feces versus the urine. The kinetics of elimination, we have what's called first order kinetic. After a drug is given orally, it will be absorbed by passive diffusion and the blood levels attained will be proportional to the amount of dose administered. Thus, the greater the dose administered, the larger will be the blood level concentration. Only makes sense. More administered drugs, larger blood level concentrations. As the drug is eliminated from the body, the concentration of the drug in the plasma will decrease equally over time. Most drugs follow the first order kinetics of elimination. We have what's called zero order kinetics. It's the elimination of a drug is at a constant rate that is not dependent upon its concentration. An example, high doses of alcohol and aspirin. Their clearance mechanism is overloaded because the elimination of that drug is at a constant rate. And figure 2.10 shows most drugs exhibiting their first order of elimination in which the drug is eliminated is equivalent to the drug concentration in the blood. Figure 2.11, if a drug elimination's mechanism becomes saturated, a drug may exhibit a zero order elimination. Let's talk about the T half-life of a drug. It is the time it takes for the concentration of the drug to be in the blood to fall to half of its original value, the T half-life. It's an indicator of how long a drug will produce its effect in the body and defines the time interval between dosage. It takes 4 to 5 half-lives for a drug to be considered eliminated from the body. At this point, a steady state has reached them. Penicillin is given 4 times a day, but amoxicillin is given 3 times a day because an amoxicillin has a longer half-life in the body, 1.3 hours, so it does not have to be administered as frequently as penicillin, which has a half-life of 30 minutes. Remember, the larger the T half-life value, the longer it takes for a drug to be eliminated for the body, so you don't have to prescribe it as often. Bioavailability. This is the rate and the extent to which a drug is absorbed into the systemic circulation. A drug delivered IV has 100% bioavailability because the entire amount of the drug enters the bloodstream. Bioavailability, the rate and to the extent to which a drug is absorbed into the systemic circulation. Drug dosing. We have what's called a loading dose. This is a high dose of a drug given initially to rapidly establish a therapeutic plasma drug concentration. You want to give the drug in high doses in order to establish a high plasma drug concentration. A maintenance dose is a lower dose, and it's just used to maintain a desired drug level. Maintenance dose. An example of this, 1,000 milligrams of penicillin VK is given immediately as a loading dose to obtain high initial blood levels, followed by 500 milligrams 4 times a day as a maintenance dose. Initially on your prescription, you would tell patients take 2 tablets stat. That means initially right away, followed by the drug being taken at a lower dose, 1 tablet 4 times a day, just to maintain that dose. Therapeutic range, it's the concentration of the drug in the plasma between the minimum effective concentration and the toxic concentration. Drug clearance. Drug clearance is the capacity of the body to remove the drug. You have to adjust the amount of dosage for children and elderly patients because they can have minimal renal and liver impairment. Pharmacodynamics. It is different than the pharmacokinetics. Remember, pharmacokinetics is ADME, absorption, distribution, metabolism, excretion, where pharmacodynamics describes the action of a drug has on the body and involves drug receptor interactions. There you have that word, receptor, pharmacodynamics. Mechanism of drug action, drug response, and dose-response relationship. Pharmacodynamics describe the action as a drug has on the body and involves drug receptor interactions, a mechanism of drug action, and drug response and dose-response relationship. Drug dose is defined as the quantity of drug administered. Drug response is the response and explains how the drug caused that response. Drug action refers to the response of living matter to administer chemicals. The site where such drug attachment takes place is termed the receptor and is regarded as being specific cell molecules. Receptors will bind either a drug that is administered into the body or an endogenous substance. Some drugs do not act upon receptors. Examples of these are alcohol, emollients, general anesthetics, and hypnotics. Instead, these drugs act as an indirect or nonspecific drug reaction. An agonist is a drug that rapidly combines with a receptor and initiates a response and rapidly dissociates or releases from the receptor. So it binds to a receptor initially, rapidly, and then it releases itself from the receptor after it binds. This drug has a high effectiveness. Most drugs used today are agonists. An antagonist, on the other hand, is a drug that binds to the receptor but does not dissociate and it has no positive response and no efficacy. It blocks the reaction of the agonist. How does it do that? It binds to receptor but does not dissociate, so it blocks the receptor site for the agonist drug. A partial agonist is a drug that slowly binds to the receptor and produces a mild therapeutic response when administered alone, but may inhibit the action of an antagonist when given concurrently, acting like an antagonist. The dose-response relationship, and these are used clinically to trial testing. It's a graded dose, and they observed and measured the patient's response, obtain a different dosage of the drug. In a graded dose response, the dose of the drug is increased. There is a gradual progressive increase in the response until a maximum effect is seen. Types of dose responses. The drug causes a response with each dose, and the maximal response is produced when all the functional receptors are occupied, and less of a response is seen when 50% of the functional receptors are occupied. Figure 215 shows a diagram of the dose-response relationship. As the dose of a drug increases, the maximal response or plateau is reached. Increasing the drug dose produces no additional therapeutic response. It's more of a flat line and could lead to death. The dose-response relationship, the potency, the dose or amount of a drug required to produce a particular or a specific biological effect relative to a given or implied standard of reference. This is the potency of a drug. The efficacy of a drug is the ability to produce a therapeutic effect regardless of the dose. Potency and efficacy often describe the success of a drug therapy. What is the therapeutic index of a dose? It's the ratio of a drug's toxic dose to its therapeutic dose. The effective dose is the drug dose that produces 50% of the maximum possible response. The lethal dose, or LE50, is the dose at which 50% of the animals die. And figure 216 effectively shows the effect low dose curve for the analgesic action of 3 narcotics and aspirin. The drug effects of therapeutic effect. It is the desirable and beneficial effect of a drug. The undesirable drug effects is the adverse drug event, the adverse drug reactions, adverse effects, toxic reactions, idiosyncratic reactions, allergic reactions, and can cause mutagenic or teratogenic reactions. Adverse drug reaction. This is a drug effect that is noxious and unintended, and that occurs at doses used in humans for prophylactic diagnosis and therapy. It requires discontinuing the use of the drug and also requires changing the drug therapy. It also requires modifying the dose. It may require admissions to a hospital. It's not predictable, unintentional. Examples of these are rash to penicillin. Adverse effects. These are undesirable side effects that develop because drugs are not totally selective in their actions. Additional drug actions at therapeutic levels that are just as typical and characteristic of a drug's pharmacological effect as a desired response. They will occur just as regularly. Every medication has a potential adverse effect. Generally, adverse effects are dose-related. The higher the dose, the greater the adverse effect. For example, adverse side effects of diphenhydramine are xerostomia, urinary retention, nausea, diarrhea, and drowsiness. Adverse effect of toxicity develop because drugs are not totally selective in their actions, and the problem of overdose leads to an increase in drug response. Injury resulting from medical intervention related to a drug. Type A adverse drug events result in toxicity, prescribe too much of a correct drug or overdose, and prescribing a drug contraindicated for a patient's condition can create adverse drug effects. Type A adverse drug events provide the correct drug but the wrong route, provide interactions. These are predictable and preventable. Type B adverse drug events, they are dose dependent, and individual response and genetic to have differences. Any type of adverse drug effect or event should be reported to the FDA through the MedWatch program, which can be reached at their website, fda.gov/medwatch. Table 2.5 shows the different drug effects. Therapeutic effects, intended pharmacological effect at a target organ. Adverse drug events, unfavorable, unintended response to a drug, predictable and preventable, and medication errors, miscalculations, overdosing, misunderstanding the verbal orders. Adverse drug reactions have adverse effects, dose-related, predictable, and affect non-target organ sites. Toxic reactions are dose-dependent and predictable. They affect non-target organs. Allergic reactions are not dose-dependent and are unpredictable. Idiosyncratic reactions generally related abnormal drug responses. Table 2.6 shows common serious adverse drug reactions, and I'll let you peruse these. From bleeding from the stomach, sleepiness, drowsiness, to liver damage. Toxic effects is defined as harmful effects associated with drug overdoses. It can be acute toxicity and chronic toxicity. They're dose-dependent and predictable on non-target organs involved. Idiosyncrasy, the unexplained, uncharacteristic response to a drug. This can be either caused by hereditary factors or genetic differences. An allergic response is a complex form between an antigen, which is a drug, and an antibody in the body. They're not dose-dependent and unpredictable. They can create mild rash to anaphylaxis. An example is this: someone who has an allergy to penicillin. The mutagenic reaction is caused by drug-induced damage to DNA. What does DNA stand for? Deoxyribonucleic acid. The display of damage is evident in children from these parents. Essentially, it is an inheritable genetic defect. Teratogenic reaction. It refers to the drug-induced damage that develops in the fetus. These drugs depend on when the drug exposure occurred during the DNA replication cycle. It can be a minor error where the damage occurred on only one base pair, or a major error where there's an abnormal protein or no protein produced. Most teratogenic drug effects become evident when the fetus is in the first trimester. Drug interactions can occur between drugs and drugs, two drugs, a drug and food, and drug and some type of disease. They produce an unusual response. Examples of drug interaction: tetracycline taken with dairy products will decrease the absorption of tetracycline. Alcohol and metronidazole causes a disulfiram reaction. Food taken with certain medications can decrease the absorption of a particular drug. Factors that affect it are biologic variations such as population, the body weight, enzyme deficiency, adaptation factors, tachyphylaxis, a placebo. What are some of the key points of this particular chapter? 100% bioavailability with IV routes of drug administration. Pharmacokinetics is a study of how drugs are handled by the body. Pharmacodynamics is the study of how drugs work and how they interact receptors. Remember, pharmacodynamics, receptors. Pharmacokinetics, ADME. A drug exerts a pharmacological effect or response. Liver cytochrome P450 enzymes are involved in many drug-drug interactions. Drugs are absorbed into the bloodstream in non-ionized, non-lipid form. Lipid solubility is one of the most important determinants of pharmacokinetic characteristics of a drug. Rate of absorption can be predicted from the knowledge of the drug's lipid solubility. Highly ionized drug cannot pass lipid membranes. Drugs are absorbed in the non-ionized lipid-soluble form. The non-ionized portion of the drug shows great lipid solubility and therefore greater absorption. Non-ionized drugs can cross through lipid membranes freely. Most drugs are either weak acids or weak bases. More key points: acids are most highly ionized at a high pH. For weak acids, the more acidic the environment, the less ionized the drug, and the more easily it crosses the lipid membrane. Bases are more ionized in an acidic environment, for example, the stomach. Okay, this is the end of Chapter 2. Remember to do the quizzes at the end of the chapter. Also, they have the resources there. And also, you may be having a quiz on Chapters 1 and Chapters 2, and I will announce when that quiz will occur sometime next week. Thank you, and I hope you have a great rest of the day. And once again, if you have any questions at all, please feel free to email me, and I'll answer those as quickly as possible. Thank you, and have a great day.